Guys, we're going to get started. So, small group so far. Hopefully more people come and join us. So, I was really excited to have the opportunity to invite Dr. Turnbull to come and join us to give ground rounds, because I reconnected with her actually at ATS last year at one of our assembly meetings, I think. It was like, I can't remember, it was critical care, the other one. But you see, I actually last saw Dr. Turnbull Alley in 2006, actually our graduation, because she and I did our masters. We slogged through our MPH together. And while I was there for an MD MPH, Dr. Turnbull was far more bold and actually did a DVM MPH program at Tufts. And then after graduation, she actually spent 2 years doing avian flu disease surveillance in Indonesia, essentially chasing chickens on the other side of the world, as she told us last night at dinner. She quickly realized her interest lay actually in epidemiology, and so she came home to complete a PhD at Hopkins with funding under a T32. She's now assistant professor in both PCCM and epidemiology, and she's been really prolific under the mentorship of Dale Needham, and she's also worked with Peter Pronovost on various grants. She primarily examines health outcomes in ICU patients, both with survivorship as well as with end-of-life practices. She's had numerous foundation and federal grants and is now funded primarily on a KO1, looking at response shift in ARDS survivors. Her current research also focuses on achieving goal, I don't know what to do about that, achieving goal-concordant care in the ICU. So with that, I'm very pleased to welcome Dr. Turnbull to give us her talk, The Right Thing Measured Poorly, an epidemiologist's view of patient-family engagement in the ICU.
That's okay. Okay, I'm going to get started, and hopefully technical stuff will work itself out. Thank you for the very kind introduction, Kasim. I do not have any financial disclosures. I will disclose, though, in case it wasn't very clear from the introduction, I am not a clinician. You may ask me about physiology and pharmacology. I will look dumb. You will look dumber for asking, and it won't get us anywhere, so please refrain from that. I'm also a bit of a pacer, and I don't like the microphone. If you can't hear me, say so, but I'm usually pretty loud, and it's not usually a problem. I'm a clinical epidemiologist, not a hospital epidemiologist. So this is an important job, but this is not my job. I work, in addition to doing my own research, I work with clinical investigators, and I help with study design and writing protocols and writing grants, and basically trying to help them ensure that they have the data they need to answer the question they want to answer, or to test the hypothesis they want to test. And then I tend to also kind of act as a translator with the statistician as well. This is a very well-known quote from a famous mathematician, John Tukey, who said, "When the right thing can only be measured poorly, the wrong thing tends to be measured well. It's often much worse to have good measurement of the wrong things, especially when in fact the wrong thing is used as an indicator of the right thing." So this is a problem I face constantly, because the right things in medicine tend to be big latent variables like healing, recovery, care. Those are important things, and they're nearly impossible to measure. And instead, we measure indicators that we hope indicate those big right things. And I spend a bunch of time, both for myself and for other clinical investigators, trying to help them figure out what should we be measuring here, and is the thing we're measuring actually a good indicator of what we care about. So today I'm going to talk about one of the most kind of extreme examples of this problem. About 25 years ago, you started seeing these kind of words show up in essays in medical journals. So patient-centered, whole patient, shared decision-making, humanistic medicine, patient engagement, and partnering with patients. These were not new ideas. If you study your medical history, most of these terms came out of the patient rights movement of the 1960s. But for whatever reason, in the early 90s, they started making their way into medical journals a lot. On my darkest days, I look at these words and I think the marketing departments of hospitals are out of control. And that's what this is. This is really painful marketing. On my best days, I think that there are a lot of doctors and clinicians who want to engage with their patients in a different way, who want to practice a different way, and don't feel supported by the system to practice that way, and are trying very hard to make that change happen. And that's really laudable. I think that's wonderful. The other side of these terms, though, is that I know they make many clinicians upset because they imply that we don't always practice this way. And especially for older clinicians who have been trying to do the right thing by their patient for decades, it can feel very threatening and accusatory to imply that this has not always happened. So, I talk about them a lot. I encourage people, don't use them as marketing, and remember that there are people who don't like them. In 2012 and 2013, I was working on a project for the Gordon and Betty Moore Foundation, which is a nonprofit in Silicon Valley. Okay, good. Who were interested in funding research into interventions to promote patient and family engagement during serious illness, particularly in the ICU. So patient and family engagement is one of those words on that list. Sounds great, but I kept pushing them. How are you going to know if these interventions work? What is our outcome? How are we evaluating these? These are the kind of metrics that we tend to use in health services research to look at broad things like, are we providing the appropriate care at the end of life? So this is a great paper by Joan Tino that I really like, that looked at things like, did people die in hospitals? Did they use an ICU in their last month of life? On the last row, we have healthcare transitions in the last 3 days. And these are all indicators of the kind of care we're providing at the end of life. And this is as good as you can do with administrative data. I'm not knocking this paper. I do think these are the right outcomes to look at when you have administrative data. But there are plenty of people for whom dying in the hospital is the right place, and using an ICU in the last month of life is the right thing for them. And transitioning in the last 3 days is completely appropriate. God forbid we ever have a patient who wants to die at home, and we could get them there, but we think they're going to die within 48 hours. My nightmare is that somebody says, well, I don't want to do that because that would be a transition in the last 3 days of life. That is the unintended consequence of these kind of outcome metrics. They're imperfect, just like Tukey was talking about. We think they indicate the right thing, but they are not the right thing for everybody. So great for health services research, but if you're the Gordon and Betty Moore Foundation and you want to do small pilot trials in the ICU with maybe a few hundred people, those aren't the outcomes you should be using. So what are the outcomes they should use? So I tried to answer this question. If an intervention successfully fosters patient-family engagement in the ICU, then we'll observe what? So I said increased incidence of goal-concordant care. And this was a grant I proposed in 2013. And of course that begged the question, well, okay, can you measure that? What is it? You have to define it, and you got to be able to measure it. So I've spent the last few years thinking about how to do that and testing whether or not it's feasible. So last year I published this conceptual framework, and it was purely focused on how would we measure this idea of goal-concordant care in the ICU. And what I came down to was answering two questions. Is this patient's goal potentially achievable, and will this intervention and treatment help achieve it? I got there mostly as a result of experiences on our hospital's clinical ethics committee. So, 10 weeks a year or something, I'm available, the pager, and frankly, I only see the very worst tip of the iceberg. And I have to constantly remind myself that I am only there if things have gone terribly wrong, and that 98% of the time, everything goes right. But when you are there and things have gone terribly wrong, one of these two things seem to not be true. Either the patient or their family had identified a goal that we don't value, or that the clinician didn't value. So the family was saying, every day alive, I don't care if they're unconscious, every day alive, that's the goal. And the clinician was saying, that's not a good enough goal. I don't value that. Or the goal was agreed upon, but not the limit that had been placed by the patient. So we all agree we want to live longer, but the patient has said, not if it means another round of chemo. We all want to be here for the grandchild to be born, but not if it means another surgery. And that was upsetting to the clinician. So I propose that if you can answer both of these questions, yes, we should call that goal-concordant care. So here's how this would actually work in real life. We had to put examples in the paper in the appendix. I have 5 patients to think about. So the first patient is a 47-year-old male with hypertension and type 2 diabetes who post-small bowel resection, he's 2 days post-op, has septic shock, and he's oliguric. The preference-sensitive intervention in question is CRRT. His goal is he wants to get back to work and to being a father per his wife. He's full code, and it's his doctor's call whether this goal is potentially achievable. And the doctor has said, yeah, that's achievable, and the treatment could help achieve that. It'll buy him time. I think his kidneys will recover. So in this case, for this patient, CRRT meets the definition of goal-concordant care. Patient 2 is a 68-year-old woman with multiple comorbidities. She has necrotizing pneumonia, ICU-acquired weakness. She's been mechanically ventilated for 14 days. And the treatment in question, the preference-sensitive treatment, which I'll define in a few slides if you hold on, is a tracheostomy. Her goal is, I want to be at my daughter's wedding in the spring. Her limitations are try to help me get better, but if my heart stops, don't do CPR, which hopefully is translated into a DNR order. Per her doctor, that's an achievable goal. She could be alive in the spring. And a tracheostomy increases her chances of being alive at that wedding. So this is goal-concordant care under the definition. The third patient is a 37-year-old man with leukemia, 2 failed bone marrow transplants, kidney failure secondary to diarrhea, secondary to graft versus host disease. The preference-sensitive treatments on the table we're debating are reintubation and a PICC line. His goal is, I want to be comfortable and in my own home. His limitations are, don't intubate me again. If I'm dying, let me go. And per his doctor, that goal is potentially achievable, but the interventions don't respect his limits and they don't help him achieve it because all treatments can be given, not IV. So if we do these things, which may or may not happen, they won't meet the goal-concordant care definition. Fourth patient is a 71-year-old man with end-stage ILD. He's been mechanically ventilated for 14 days. His hypoxia is getting worse. He's not a transplant candidate. His preference-sensitive intervention, again, is a tracheostomy. And his goal is beat my ILD and hike in the mountains next summer. He's full code. His doctor has said that's not achievable, not at this stage in his disease. And a tracheostomy is not going to help him achieve it. It'll keep him alive, but it will not help him achieve that goal. So, again, the tracheostomy may happen, but by this definition, for purposes of this study, that's not considered goal-concordant care. And our last patient is an 87-year-old woman with advanced dementia. She has ARDS secondary to influenza pneumonia. IHD is in question. She's on IHD, and now the question is whether she gets a long-term dialysis catheter. Her son is saying she'd definitely want to be alive. She wouldn't mind living in a nursing facility. She's full code. And her doctor said, yeah, that's potentially achievable. She could live in a nursing home, and the long-term dialysis catheter would help facilitate that. So this counts. This would be goal-concordant care under the definition. Even though I know many people look at that and say, that's not a goal I value. That's not a way I'd want to live. Yeah. Yeah. Well, so this is a great example of if you sat down with him and had a discussion, went over his prognosis, and he changed his goal, then that could be goal-concordant care. But it depends on what his goal is. So measuring this way creates an incentive to be very direct about prognosis and to help patients find achievable goals. So after that discussion, if he said, yeah, no, even if I'm just alive next summer, that's enough for me, then it is. Of course, right. And that's why this is something you have to measure longitudinally across the ICU stay. Keep going. Oh, at their daughter's wedding. She can. This is goal-concordant care. Yeah. Yeah. So, okay. No. So one of the reasons to measure this way is that it means that more complex patients contribute more data than short-stay easy patients, right? If there's no big decision that ever gets made, that patient should not weigh as heavily as a patient who is with us for weeks and weeks and weeks and faces multiple decisions. It's not as simple as all or nothing. We can be not in line with a patient initially and then get on the same page about what goals are and what prognosis looks like. So you can imagine a situation where in your ICU there are 48 preference-sensitive treatment decisions that get made over the course of a month. 15 of them are deemed as goal-discordant. Now you have a rate. Now you have a number that you can talk about for research purposes, and you can put a confidence interval. So 32.3 discordant treatments per 100 preference-sensitive decisions. Okay, this is a fine idea. It's a proposal, but is it actually feasible? There are 3 big barriers between talking about this and actually being able to implement it in a clinical study. The first is we have to have some agreement on which treatments constitute preference-sensitive decisions, because not everything is. The second is families or patients, but a lot of our patients don't have capacity, so usually it's families, have to be able to identify goals and limitations, which, as already pointed out, are time-dependent. They're changing longitudinally across the ICU stay. And third, intensivists have to agree on whether patient goals are potentially achievable and whether treatments help to achieve them. So first question, which treatments should be reviewed? Because not everyone requires consideration of patient goals. This is in line with the ATS and SACM policy on shared decision-making, which says it's logistically impractical and ethically generally unwarranted to involve patients and surrogates in each of these medical decisions. When important preference-sensitive decisions arise, or choices arise, clinicians should engage the patient or surrogate to provide an opportunity for shared decision-making. Great, I agree. There's no definition in the policy on what constitutes an important preference-sensitive decision. So to try and address that, for my purposes of doing small studies in my ICU, I performed a Delphi study with 6 hospitals in my region. So a Delphi process, modified Delphi process, just as quick background, is one way to reach consensus on something when you don't have empiric data. Right? So there isn't really great data you can pull on this. But a Delphi process developed by the Rand Corporation during the Cold War was to forecast things, usually related to warfare, but now gets used in medicine too. You get a bunch of experts together. They anonymously all sit on a panel, so they don't know who else is on the panel. You ask them questions or ask them to vote on something. They vote in a round, and then they see their answer and a summary of everybody else's answer anonymized. So the 100-pound gorilla in the room can't influence everyone else, but they can see, am I an outlier? Are my opinions really different than all the other experts? And then you have another round of voting and repeat until some kind of consensus is reached. And you have to have a predefined definition of how much consensus you need for action. The other nice thing about it is because it's anonymous, no one ever has to say they were wrong. Nobody ever has to know if you change your vote. So I went to 6 hospitals in the Clinical Research Network at Johns Hopkins. Each of them contributed an intensivist, an ICU nurse, a former ICU patient, and a family member of a former patient to represent their hospital to try and come to some consensus on what are we going to use as preference-sensitive treatments for our ICU. They had 3 criteria. It had to be potentially incompatible with a patient treatment goal. It had to have the potential to cause physical, emotional, or financial harm. And it had to be anticipated on a non-emergent basis. So CPR is not on here because it often happens emergently. These had to be decisions that there's no reason we can't sit down with the family and make. So non-emergencies. For each potential, we started with a huge number, it got whittled, and then for each of the kind of second round interventions, we needed informed voters. And since a lot of the representatives are family members or patients, we needed to do voter education in a way they could understand to be experts on this panel. So for all of the considered interventions, we made a web page like this that answered 6 questions. What is it? What does it do? How might this intervention harm a patient? How quickly does this decision need to be made? Why might some people choose this intervention? And why might some people choose not to have this intervention? So those are still up on the website. If you're ever faced with trying to talk to somebody about one of these interventions and you're looking for some words to steal or some pictures to show or a website, feel free to go there. They're sitting up there. And after multiple rounds of voting, these are the things that they agreed on. I didn't have any say. This is where they got to. And it's been useful for my research to just have a list of things that we can agree probably constitute a discussion, some of them. Okay, so second barrier to feasibility is, can families identify goals and limitations? Because most families arrive completely unprepared to be proxies. I understand ideally there'd be advanced care planning, families would be ready. If that happens and I'm out of a job, that's fantastic. I'm not too concerned. Most people aren't ready. So we worked for about a year with various stakeholders in the hospital, including the Patient Family Advisory Council, obviously the providers in our MICU, nursing, chaplaincy, social work, and the legal department, to try and put together an intervention designed for families when they arrive to prepare them to be better proxies for their loved ones. And this was a compromise, this intervention. As you can imagine, when you have to make that many parties happy, you end up with a compromise. So We screened our ICU daily for 96 days. We said any patient who had been there for at least 24 hours was eligible. They had to be physically present in the NICU. I wasn't going to make a phone call. I needed to talk to you face to face. So obviously unbefriended patients couldn't be included. You had to have a family member there and they had to speak English. We ended up with 122 proxies for 111 patients. There were 11 that had 2 because the first person we interviewed turned out not to be the legal healthcare proxy. Just to back up for a second. So I use the term proxy because in Maryland, healthcare agents and healthcare surrogates have slightly different rights, and the term proxy is an umbrella term that encompasses all of them. So if that's unfamiliar territory, you can imagine. Okay, so we ended up with this little booklet, and the booklet was really just a tool. So to be in the study, you were enrolled, and then we said, I try to meet with everybody who's here for at least 24 hours. This is for you. You can have this, but I have to read it aloud under study protocol. We did that in part because with lots of piloting, we realized some of our families, even written at a 4th grade level, cannot read. Second of all, I needed to be sure that from a study standpoint, everybody got the same dose of an intervention, right? Because if you just hand it to them, some of them are never going to read it. Some are going to read a few pages of it. I wanted to know that everybody heard the same thing, so I said it aloud. And I had a bedside nurse who was donating her time to this project who did it as well. So this is what I said to 122 families. Someone you care about is in the intensive care unit or ICU. The ICU is a special part of the hospital. Some people in the ICU are sick enough to die. Many ICU patients are too sick to talk. If your loved one didn't choose someone to speak for them, a Maryland law says who may speak for them. And the person who speaks for the patient is called the proxy. Wait, what if I don't want to be the proxy? You don't have to be the proxy. If you don't want to be the proxy, you should tell a doctor, nurse, or social worker. They will help you find someone else to be the proxy. If you are the proxy, you have a big job. The proxy's job is to tell doctors about the sick person's goals. Doctors need this information. It's okay if you're not sure what your loved one would say. It's also okay for goals to change over time. For some people, the goal is to be 100% cured. But many people have problems that cannot be cured, like severe lung disease, kidney failure, and end-stage cancer. These people have important goals too. For example, sometimes the goal is to return to a job or hobby the patient loves. For some people, the goal is to live long enough to see an important event, like a graduation, a birth, a wedding, or the Ravens postseason. For other people, the goal is to be awake and comfortable before they die. Some patients are so sick that their goals cannot be reached. If you're worried that your loved one is dying and treatment will not help, ask a doctor, is it time to let go? Proxies are not alone. Most proxies work with their families. Some proxies work with their priest, pastor, rabbi, imam, or faith leader. All religious leaders are welcome in the ICU. There are also chaplains in the hospital 24 hours a day. Some proxies want to look things up and make decisions on their own. That's okay. Other proxies want doctors to make recommendations. That's also okay. Ask, what do you recommend? Or what would you do if she was your family? Here are 6 tips for being a great proxy. 1, explain your loved one's goals. When you meet a new doctor or nurse, tell them you're the proxy. Don't assume they know you or what matters to your loved one. Number 2, give doctors phone numbers to call or explain the best way to reach you. It's very important they know how to reach you in an emergency. Number 3, ask doctors what's most likely to happen. Nobody knows exactly what will happen, but you need to know if your loved one may recover, never return home, or die. Number 4, you may be asked if your loved one would want specific treatments or tests. This can be a hard question. Ask, will it help her reach her goal? What are her other options? Number 5, meet the social worker in the ICU. She can help you and your loved one get the support you need. And number 6, make sure you sleep and eat to stay healthy. Being the proxy can be very stressful. Then we had our 4 suggested questions for them to ask and the contact information for the support services in the NICU. Okay, so after reading that to them, we had a series of questions. I'm just going to show you the results from 2 questions that addressed feasibility. The first was we asked them, I'm using my father's name, but we used the patient's name. In your opinion, which of the following options best describes Walter's goal right now? We asked this as an open-ended question and let them just talk for a long time, and then we asked it with multiple choices. And this is what people said. These are not categories that we created. This is an existing scale developed in Iowa. Really interesting to me was that this distribution of responses was really close to what they found in Iowa, even though it's Baltimore City, it's 500,000 people, it's majority African American, it's very different. We then asked, in your opinion, how does, and importantly, everybody can answer this, everybody can answer this question about goals, except for 2 people who said they were unsure. We then asked, in your opinion, how does Walter want doctors and nurses in the ICU to treat him? Which of the following statements sounds most like what he would say? Use life support machines to keep me alive no matter what. If my heart stops, do CPR. Use life support machines to keep me alive no matter what. But if my heart stops, don't do CPR. Try to help me get better, but don't use life support machines. And if my heart stops, don't do CPR. Focus on keeping me as comfortable as possible, even if that means I die sooner, or I don't know what he or she would say. This was a much, much harder question for people. 25% of them didn't feel they could answer that. 75% were pretty confident in answering that. And obviously these translate into code status orders. Okay, so can families identify goals and limitations? About 75% of them can. The other 25% don't know where the limit lies. I don't think that that is, a fatal flaw because, we already deal with this in practice, which is that if people don't know, we preserve life. That's the default. The third barrier to feasibility was, can intensivists agree on whether patient goals are potentially achievable and whether treatments can help reach those goals? To try and address this, we did a simulation study. So the goal was to estimate inter-rater reliability between intensivists if they had all this information. To do that, we started by screening the electronic medical record for all of 2015 and all of the 3 ICUs at the hospital for these interventions we had previously identified as potentially as preference sensitive. So we got this algorithm, we found all the times these things had happened, and then we took a random sample of 40 instances of each, so making sure there was no patient overlap, so each patient is only in there once. So we had a sample of 240 actual patients who had received these 6 interventions. And the list of interventions went from 8 to 6 just because we couldn't make the algorithm find 2 of them, the way things were recorded in the EMR. So those are our patients. 39 people got dropped because the algorithm was wrong. When it said an event had happened, it actually hadn't. So we had a sample of 201. This is what those patients looked like. They're pretty normal. I don't know, nothing stood out to me about them. They're in our medical, our surgical, and our surgical oncology ICUs. So from those 240, we then had to have data on what are their goals and limitations. And those things just aren't consistently recorded in the medical record. One of the things I looked at when we did the study with the booklet was we asked people where are their limits, which of the following sounds like what they would say, and then we compared it to what was actually in the medical record as their code status order, and the concordance was not great. And a lot of times, in fact, nobody had asked at all. So we decided that we couldn't use the data that was already in the EMR to decide limits, and it was very rare there were any statements about patient goals. So instead what we did is we took the data from the booklet trial and looked at the 10 most common combinations of answers that people gave about goals and limits. Said, okay, these are the 10 most common things people say, and then we randomly assigned those to the 240 people, became 201 people in the simulation study. Then I hired 6 critical care fellows, 2 from PCCM, 2 from anesthesia and critical care. They all had to work independently, but each of these records got reviewed. The patient records got reviewed by 3 of them each. Before they started doing chart review, we had an in-person training. They had this operations manual. They had practice patients to do, and they were getting paid a fair bit to do this carefully. And for each patient they looked at, they had to again answer those 2 questions. Is this goal potentially achievable, and will the treatment help? And to guide them, we created ways to interpret statements about goals. So we made these up. We said, when you see that goal, this is what is an acceptable quality of life for those patients. So they were all working off the same definition. And then we give them examples like this. We said, here's an example of what would count and what wouldn't count, a whole bunch of practice. They had to get the practice patients right. And then we sent them into the wild and said, okay, chart review. So here's what we found. With 201 patients, there were 22 patients where there was unanimous agreement. This goal is not achievable. There were 114 patients where there was unanimous agreement amongst 3 fellows. This goal is potentially achievable. And in about a third of patients, there was disagreement amongst the raters about whether the patient's goal is achievable. So it was hard, even after kind of getting everybody on the same page with that training. For the patients where they said the goal is potentially achievable, they then answered the second question, will performing or continuing to use this intervention help achieve the patient's goal? 83% of the time there was unanimous agreement across all of the fellows, 17% of the time there wasn't. So clearly the first question is harder than the second. When we're having disagreements about whether an intervention is appropriate, it's usually around whether or not the goal is achievable. It's about prognosis. This is looking at individual pairs of raters, so A through F are the fellows. And there were pairs of people, like C and E, who were mind melded. They agreed almost all the time on both of these questions. And there were people like B and D, who were barely better than flipping a coin on what was going to happen to this patient. I don't know what to say about that, except that there's enormous variability between clinicians and what they think can be achieved for a patient. And then this was just estimating the interclass correlation through a 3-level random effects model. And ICC ranges from 0 to 1.0, so 0.50 is kind of halfway in the middle. It's moderate agreement. Yeah,
I was just asking if you looked at the same program versus other fellowship program.
Yeah. So this model, the second model, the first model is just null effect. The second adds patient characteristics, so things like the patient age and SOFA score and days in the ICU. And the third model adds in data about the fellowship program, and it just doesn't move the ICC much. I know that when I went into it, the PCCM fellows and the ACCM fellows were all like, we're on the same club. Like, we're going to agree. And if you look at this, A, B, and C are PCCM, and D, E, and F are ACCM. So it didn't work out that way at all. People were not in agreement with the people they thought they'd be in agreement with. Okay, sorry, going the wrong way. Okay, so there's limitations to this though. The study, it's simulated patient scenarios. They're randomly assigned goals and limitations, which might never have been that patient's goal or limitation. So we probably created some pretty crazy scenarios during random assignment. They also weren't allowed to discuss with one another. So potentially, if those fellows had been sitting in the same room discussing, they might have come to more agreement. And then finally, single institution and their fellows, would it be different with attendings? I'm not sure. So kind of early days, but starting to think about, is this an outcome we can use? So is it feasible? Well, with simulated patients, moderate agreement. Okay, so back to our big question. Can you measure the incidence of Goal-concordant ICU care? Maybe. It's definitely not ready for implementation yet. The next step would be a clinical feasibility study with real patients and real families being followed longitudinally and asked about this stuff. That's on the radar for hopefully in the next year or two. But we're still kind of stuck here, which is this issue of we can measure the right thing poorly, or we can measure these indicators well. But the indicators are not really great indicators for the kind of care we want to provide. Before you completely throw your hands up in the air and feel like this is impossible, you can't measure this touchy-feely stuff, just give up on it. I want to try and provide a little historical perspective. Well, first of all, before I do that, I feel more convinced than ever this year because there have been a bunch of publications that came out this year that completely agreed with this assumption that this is the right thing to measure. So this was a Delphi done by Rebecca Sidori out of UCSF, asking what is the most important outcome of advanced care planning, and number one was care consistent with goals. And this was patients and families and doctors together rating all sorts of things. And again, they raised questions. Can that be measured reliably? But it was really rewarding 5 years after writing this grant to see, like, palliative care completely agrees with this outcome. That's great, but, can we measure it? And this came out this year on the Journal of Palliative Care, saying that because we don't know how to measure this yet, here are implementation-ready measures. Well, yeah, these are these imperfect indicators. They're implementation ready, but they're not what we really want to measure. So the timing and setting of your serious illness communication, yeah, it's great. I hope we do that. But if it doesn't influence care, that's not the outcome we care about. Patient experience of communication and care, yeah, patient experience matters, but that sounds a lot like satisfaction. And that is not, at the end of the day, what matters. I'm not going to chase HCAHPS scores. And the third is caregiver bereavement surveys, which, yes, I think that matters, but that only applies to the patients who die. And the patients who don't die matter too. So we need a measure that works for the patients who don't die. So here we are, we're stuck, right? Good thing, the right thing measured poorly, the not right things measured well. We have to make a choice. At the moment we do, but this is kind of typical in the evolution of the scientific idea. So initially it's a concept, and people write essays and conceptual models, and we just talk about it and we don't know how to measure it. Then what tends to happen is somebody publishes a paper using some unvalidated instrument, and it gets in a big journal, and people realize you can measure this, and then it is game on. Then we have the Cambrian instrument explosion, right, where everybody starts making instruments until there are too many. And everybody's trying to validate them. A lot of them are bad. Some of them go extinct, but there's lots and lots of them. And this has been borne out in other fields. So this was a scoping review I did on outcomes after ICU discharge between 1970 and 2013. And it was fun because you could see this evolutionary process happen in this field. So the top line, the solid line here are observational studies, and the dashed line are trials that involve ICU survivors being measured post-ICU discharge. And this is the paper that was that first paper that created the instrument explosion. It was really fun to read. It was in NHAM, and it got labeled a special article, right? So everyone's going to pay attention. And if you look at what they looked at and what they measured, it is so homegrown and unvalidated and subjective. Fully recovered, progressing to full recovery, partial recovery at best, and no improvement. Never defined anywhere how any of those things are being measured, right? Just totally subjective. Looks, I think he's getting better, right? If you look at the tables, again, no validated instruments, totally subjective, just kind of a feel, because they don't have any. I'm not knocking this. They didn't have the instruments to measure this stuff, so they were doing the best they could. And they said in their discussion, there are few reports on the outcomes of intensive care, and in the absence of methods to compare one intensive population to another, results are difficult to interpret. Finally, standardized terminology for critical illness is imperative, so that patients from one intensive care unit can be compared to patients from another. And that's what happened, right? Suddenly, we all started looking at this, people started developing measures, and it took off. The problem in this field now is we have too many instruments. So for 425 publications, there were 250 different measurement instruments used. So again, your results become uncomparable. That's another story for another day. We're working on a core outcome measure set to try and pare that down. This is an example for just looking at PTSD symptoms in ICU survivors. There were 70 articles that used all these different instruments, and many of them used multiple, again, making it really hard to compare. So, now we're at this phase in research looking at long-term outcomes of ICU care, but, we're trying to get into the Jurassic era where there's just one or two big megafauna, one or two big, instruments we all use, the dinosaurs that take over. That's the push in that field. But for goal-concordant care, we're still back here in the conceptual era. We're still trying to figure out, can you measure this? And I would encourage you to, hang on, be patient. It's going to take a while. Somebody's going to do it eventually. So clinical take-homes, when I came to speak here, I asked Kasum, is it okay if I talk about method stuff? Is that going to be okay? I know I'm not a clinician. And she said, you guys were cool. But she also basically said, if you can talk about some things that would be useful at the bedside, that's great too. So here's some small things may be useful to you. The guide is up on my website under a Creative Commons license. So if you want to use something about it or change some bit of it, go ahead and download it, change it to be appropriate for your ICU. Just, keep giving us credit. I will say about this, please do not leave it in your waiting room, because I didn't show the data where we asked people, is this important? Is this appropriate? Is it upsetting? And what we found is all but 2 people out of 122 said this is very important, this is completely appropriate. But 44% of them also said this is very upsetting. And the people who said this is very upsetting also said it's really important. So, you don't want to leave something that's very upsetting just sitting around in a waiting room. That's not good. You want to have somebody with them when they find it. The other thing I'd say is that it sets, you're saying something when you leave it there to be found versus when you can say it out loud to people. So when you say it out loud to people, you're saying this isn't shameful, these aren't bad things to say in this setting, this is how we talk here, and we're going to make it normal. When you leave it to be found, it's like your parents leaving a book on sex ed on your bed, right? Which says, I want you to know this, but we don't talk about this stuff, right? I just want you to know, and just don't bring it up, right? So don't leave it to be found like that. Demonstrate to people, no, we talk about this stuff. Here's what you need to know. The second thing is, we spent a lot of time figuring out how to talk about these procedures in ways that people on our Patient Family Advisory Council can understand. So these websites are up. You're welcome to steal anything you want from them. And then I think just thinking about this framework about what is this patient's goal? Can I help them formulate an achievable goal? What are their limits? And then developing, preference-sensitive treatments that remind you, do we need to check in on their goals and limits? One thing I want to say quickly about the goals and limits, some people kind of feel like that's just not how it works. We are the experts, and they come to us. Everybody wants to be alive, and they come to us, and we are the best people to figure out how to do that. And that is true. But I would say there are other relationships with experts that you are used to where there are goals and limits. So when you go to a financial planner, right, they're an expert. They know something that you don't. And you go in with a goal. You might go in and say, I want to retire ASAP, or in 5 years. Like, I want out. You make me a goal. You make me a plan to get there. But if they respond to that and say, I gotcha, you can retire in 6 months, you're going to move to Mississippi, you're going to be like, well, hold on. Like, I have limits on what I will do to retire soon. If I go in and say, I want to pay off my student loans ASAP, and they're like, yeah, you walk 3 blocks that way and you talk to Dante and he'll give you a bag of fentanyl, you're going to be like, I have limits. It has to be legal. And our patients often feel the same way. They come in with these big goals, and we assume there's no limits. But they do. They do have limits. They just don't always know where they are. Help them figure that out. And then if you want to find me and ask me anything else, I'm all over the web, and you can pick fights on Twitter with me. So, thanks very much. Questions or lunch?
So you alluded to this early on, that there's often provider preferences that aren't really being talked about or even acknowledged, self-acknowledged or even acknowledged by colleagues. So there's a lot of, there's folks like Pittsburgh and other places have done some research on this, that provider preference often influences how you're presenting the data, how you're eliciting goals, if you do at all.
Yeah.
So how does that figure into the work that you've done in terms of the conceptual framework versus or at least did any of that come out when you were talking to families and surrogates?
Well, so I don't think there's any doubt that the provider preferences play a huge role. I mean, we see enormous differences across providers in what happens. I don't think that pretending providers can be robots is helpful. They're not. And the Pear Center and Scott Halpern and kind of his group at UPenn have talked a lot about, nudges and advocating for the treatment plan you truly believe is best. I don't think that we can pretend that that's not going to happen. And I'd rather we were explicit and thought to ourselves, what do we truly believe is best for this patient who has this goal? Now, obviously, there are limits in that if you if the patient wants something that you feel is entirely wrong, that's when you have to have a robust conscientious objection policy available. And we certainly have had providers who have said, a neurologist who was like, I don't do brain death assessments on kids under a year or something. And we're like, well, that has to get done. What do we do if that's not okay with you? And his colleagues stepped in and were like, we will do those. If that violates a core principle of who he is, it's legal, it's part of standard practice. We can't deny a patient something that is legal and part of standard practice because of your beliefs, but you want to preserve your beliefs. And so, I think the first step towards using that effectively is people feeling that they can be open about how their personal beliefs influence their care. It has to not be taboo to say that.
I feel like though it's hard for some because we try to be all altruistic. It's hard to disentangle that. What our own personal biases that we are bringing to the table.
Yeah, and there are going to be patients who choose things we don't like. That's within their rights. But if it gets to a point where you truly feel you can't sleep at night, like this is a violation of something that is core to my being, then you have to speak up and talk to colleagues and see if there are people who will. We also encourage. That's why our ethics page is 24/7 too. We're happy to talk to you about that. But I understand it. People get pushed into really uncomfortable places, especially when they're dealing with a family whose beliefs and values are extremely different from their own. Yeah.
Question. So I want to hear your thoughts about when you mentioned Scott Halpern. There was this article last year in JAMA about the discriminative accuracy between physicians and ICU nurses in predicting functional outcomes and survival 6 months on.
Yeah.
We can't seem to agree ourselves. I don't know how the patient's going to look like in 6 months.
Yeah.
Very hard to approach proxies with prognosis when we're so
Right.
poor.
Yeah. No, I think you're totally right, and that's why it's important to say I'm not sure. You can't be sure. I'm actually much more concerned about providers who are like this is your prognosis than about ones who go I can't be sure. I think the best case scenario is here and the worst is here, and you're somewhere in the middle, but I don't know where. Admitting uncertainty is important, and most families. You got to remember, I think it's Doug White's group has done a bunch of work on like why is there a difference between what the prognosis the doctor gives in the family. And about 50% of it is not understanding, and 50% of it is I understand you, I just don't believe you. So I tend to tell people like it's okay to tell the family what you think because there's a good chance they won't believe you anyway. So just tell them what you think. Yeah.
One of the problems was practice medicine. No one knows what this facility is going to the real world. Say family medicine.
Mm-hmm.
In New York City, a family computer, I'll tell you, a college professor, who comes in with 22 shirts, he has had 3 ex-wives, his mother from major spinal syndrome. I said, who's your surrogate? Who's your help?
Right.
A woman I know, she's very active. She works out all the time. My secretary said, look, I don't have a family, I have to have a healthcare person. She comes in and she hands him a paper with my name on it.
Right. Yeah, you can't do it.
Right.
Right. So unbefriended patients.
This is a very common thing which we all see.
Yeah, yeah. So there's a paper, I can't remember who it is, who looked at across ICUs.
That's the word.
Unbefriended, it's a legal term. To be unbefriended, so you literally have no one who can speak about you. And it's a problem because, the court, we've done this, we've gone to court to get court-appointed guardians for those people, but in most states don't fund those people. They don't put money forward to have for the guardians unless it's hard to find people who will do it. It tends to be civil servants, at least in Maryland, who get appointed, and then many of them, when we have had them appointed, never even come to the ICU and see the patient. So, and the different state by state, what a guardian can decide is totally state dependent. So if we want a court-appointed guardian with the ability to withdraw life support, we have to specifically ask for it in court, and they don't always give that. So sometimes you get now you've got a proxy or a court-appointed guardian, they still can't decide this, now you have to go back to court again. It's a long, frustrating process, and it's a problem that it will only get worse as the rates of divorce and small numbers of children and people living longer continue to happen. We don't, essentially it's an adult foster care system that is underfunded by the country.
Sorry, not monopolizing questions, but what do you think the impact is, or do you think it's worth studying the idea of care transitions between the providers? Because in our shop, we switch attendings every week, and sometimes every 5 days because if something different for the weekend.
Right.
And for sure, we try to communicate sort of like what the tenor of the conversation has been, the content of the conversation with families in past.
Yeah.
But that doesn't necessarily take into consideration, what the residents are telling that the families, or potentially what the fellow has already communicated, sometimes what the nurses have communicated with families. So there's a lot of different themselves may have a different take on things they're following. What's going to happen to the patients' families who are trying, when you're trying to list the final goals?
One of the easiest way to piss off a family is to tell them conflicting information, right? So if one person tells them one thing and another tells them another, that's not like trust gets lost really fast in that situation. I also appreciate the fact that residents and fellows and nurses, just because of the way we work, tend to be very aware of the amount of variability between attendings because they get the whiplash. One person goes off and another comes on and everybody's care plan changes. Attendings often, ironically, because they're not working with their colleagues, they don't understand just how different they are from their colleagues. They don't see it. And it's hard to measure because you have to, it can be hard to assign a patient's care to an attending. You know, if you had them Thursday, Friday, and somebody else covered the weekend and then you came back, does the trach that happened on Monday, apropos of a discussion on Friday, which doctor do I assign for that? Right? So it's really hard to measure that variability. I don't have an easy answer. I know, you know, at Hopkins we just had a long discussion where the director was floating the idea of going to month-long service. And yeah, it didn't go over. It didn't go over at all. That's not going to happen. But he did it in part for this exact reason. Right? Yeah. Yeah. That was everyone's reaction.